Hi, this is Chris Westfall, the Senior Savings Network, and with me today is a very special guest I believe will bring you some value in what you can discover about your own health and how you may help someone else who may be going through the same thing. With me today is a very special guest, Ann Lake, who's a doctor of nursing practice. She is the Fracture Liaison Service Program Coordinator for Wake Forest Baptist Medical Center in Winston-Salem, North Carolina, and received her doctorate in nursing practice from Frontier Nursing University in 2011. With her doctoral thesis focused on implementation of bone health protocols in the orthopedic practice. After completing her DNP, she became involved with the National Osteoporosis Foundation, for which she is a current board member and is a co-chair of the Quality Committee for the NOF. She's a current national speaker on osteoporosis and setting up fracture liaison programs. She's a consultant with the National Bone Health Alliance and is a clinical advisor on the disease state of osteoporosis. Dr. Lake understands a best practice mindset for gaining support from stakeholders and staff in order to build a seamless fracture liaison program, whether it be an individual practice, multi-specialty group, or an institutionally based program. She is a published author on the topic, and she remains a strong patient advocate for quality and chronic disease management of osteoporosis. Dr. Lake, thanks for joining me today.
Thank you so much. It is a privilege to be speaking to you and also the people that you serve so greatly, and I'm honored. Thank you so much.
Can you tell me, what are the signs and symptoms of osteoporosis? How do we even know if we have it?
Well, I think it's important to kind of understand what happens in the bones as we age. When we're younger, we are building bone much faster than we're losing. When we get in our 20s, 30s, 40s, we have pretty much an equal bone balance, so we're losing bone and building bone about equally. I usually say your bone bank account is pretty equivalent. When you reach your late 40s, 5th, 6th, and 7th decade of life and so on, what happens is the switch changes. So we begin to lose bones faster than we're able to replace. There's various reasons for that, certain causes for that. Most of it is hormonal deficiency. Women lose bones very rapidly the first 5 years after menopause. Men, if they have low testosterone, can certainly lose bone quicker. However, by 65, men and women are losing bone about the same rate. But the real issue is that not only are we losing bone faster than we're able to replace as we get older, the quality of our bone is what our age is. So when we think about what's happening in our body as we age, we can see gray hair, we can see wrinkles. So we can see signs of aging, but a lot of times we don't know that our bones are aging, or we don't think our bones are aging. And so that's where the subtle things happen with osteoporosis. So some of the signs, people say to me a lot, oh yeah, I'm shrinking, it's normal. Well, no, I'm here to tell you it's not normal to shrink when you get older. So if you have certain signs, if you've lost height of 1.5 to 2 inches since your 20s, if you have a sedentary lifestyle, if you have a low vitamin D level, if you have brittle fingernails, or you've lost a lot of weight and you have a low muscle mass, those kind of things are a good indication that you're probably losing bone much faster. But the key factor is that 1 in 2 females over the age of 50 and 1 in 4 males over the age of 50 are likely to have a fracture or a broken bone from weak, brittle bones related to osteoporosis. And they may not even know they have osteoporosis until they have a fracture. And that's what we want to try to prevent.
What can they do to slow down this natural progression of bone loss over time? Is there anything they can do to slow it down or fix it?
That's a great question also. I kind of use the idea of what we do with our skin. We think we can stop aging with certain treatments, plastic surgeries, and certain injections and those kind of things. But unfortunately, for our bones, the best we can do is to maintain a very healthy, active lifestyle, and to make sure that our vitamin D levels are where they need to be. We want to make sure that we're taking enough calcium and consuming enough calcium at the guidance of our primary care provider or our physician. And we also want to make sure that if you can, incorporate some kind of resistance exercises that are very, very important, because the bones love some type of impact and resistance, and that helps them remodel. Now, if a person has low bone mass, the only way we can identify low bone mass is by doing what's a test called a bone density test. And a bone density test simply just tells us how thick a person's bones are. Unfortunately, it doesn't tell us anything about the quality. So we have to look at the patient's age, we have to look at their medications, their medical conditions, and any of those things that may affect the quality of their bone as well. So when we have the tool of the bone density and we have the history and the information that we need based on the patient's medical conditions, et cetera, then we can make a better treatment decision for treatment. So if a patient needs pharmacological treatment, then we would suggest certain medications for that particular treatment to either slow down or actually rebuild the bone.
Rebuilding the bone. That sounds like something from the $6 Million Man. We can rebuild it. How does that work? Is that really possible?
It is. A lot of people get confused with arthritis and osteoporosis, but I'm here to let everyone know that you can have arthritis and not have osteoporosis or bone loss. You could have osteoporosis and bone loss and not have arthritis, but most of my patient population, 50 and older, has a combination of both. So when we talk about arthritis and we talk about what you were referencing, the $6 Million Man, there were total joint replacements done on the $6 Million Man, and I don't know if he had a cornea replacement or what happened, but whatever, his eye and lifty waxy ear and all that stuff, that would be great if we could do all that. But when it comes to the inside of the bone is like a honeycomb, and as we get older, that honeycomb starts to thin out. So there are medications that there are two groups of medications, actually. One group of medications will slow the bone loss down, and the other group of medication can actually help rebuild the bone. And I'll see if you have I can answer that a little more succinctly if you'd like.
That's incredible. So you can actually start to rebuild the bone. Is it a situation where through these kind of drugs, you could actually rebuild the bone to the state that it was maybe before they started osteoporosis, or is it, how significant could they rebuild the bone?
So well, first of all, number one, the goal of treatment, if a patient has osteoporosis, if they're at high risk for breaking a bone, then I think it's important to understand that there's certain criteria that they would have to meet to be placed on the bone rebuilding medication. So taking it back just a step, when it comes to osteoporosis treatment and management, there's medications that will slow the bone loss down and medications that will actually rebuild. Patients that are postmenopausal women that have had a fracture, a fragility fracture, or what we call a fragile bone fracture, or they have other risk factors that put them at high risk for a fracture. Perhaps they had been on another treatment for osteoporosis and they fractured while they were on treatment, or maybe they couldn't tolerate that treatment. So that would be a criteria for going on the medications. There is a medication that will help effectively rebuild the bone faster than someone's losing for male patients. If a male patient has bone loss or osteoporosis related to low testosterone, or they have it just from age related and they suffered a fracture, then that would be the criteria for that medication. And then also there's a medication that patients that are on long-term steroids, that is a big factor. We call them medications that are bad to the bone, and I'm not going to go through that list today, but that's another reason to talk to your care provider, what medications you may be on that could be affecting your bone, but particularly with steroid treatment, patients are at much higher risk for poor quality. So the bone rebuilding medication that's out there now can certainly help with that, with glucosteroid-induced osteoporosis. So how it works is it helps the body utilize a natural occurring hormone that it already has called the parathyroid hormone. And that hormone is responsible for our bone metabolism. I'm not going to go into the scientific information there, but really it helps us build bones faster than we're losing. There's two medications currently available. One is available that is both indicated for males and females, and then there's one that's indicated for just females at this time. But they both show an impact of increasing bone density over bone loss. The other factor that we found through research studies, is that these particular treatments actually have been proven to improve the quality of the bone as well. So in answer to your question, in essence, there is some indication that there is some reversal of the aging process and the quality of the bone with these particular treatments.
Now, our clients are on Medicare. They're all throughout the country. And if they go to their primary care doctor and they find out through education like this that there is such a solution, that maybe they've suffered a fracture, multiple fractures, and they're speaking with their primary or their internal doctor, and they find out, oh my gosh, there is something else out there. How likely is their primary care physician, how likely are they to know about these specific drugs that actually rebuild the bone?
Well, they're going to be familiar with them. There's been a lot of marketing done in the past several years, really for greater awareness in primary care. One of the things that we run into as a specialist in this field is that there's varying opinions from experts. Certain societies have their own opinion about a certain treatment protocol and where you should start with the treatment of osteoporosis. Some of them are really great. They're really based on the evidence and the science, and some of them are very weak, but they're not real consistent with what we're seeing really with the greater science. So if they go to primary care provider, the primary care provider should know about any treatment available for this disease. That the patient needs to be empowered with all the knowledge they need to make the best treatment decision for themselves. So they should be able to trust that their primary care provider is up to date on the current treatment options. What they may run into, however, is the stipulation that, well, I'm sure everyone's familiar with something that was just signed into law, something called stepwise therapy.
You're diagnosed with an illness. Your doctor gives you the prescription to help until the insurance company says, not so fast.
They put the dollars ahead of a patient's health and well-being.
7 investigator Ross Jones revealing what the insurance companies now want you doing before you get that drug and what it's like for those fighting for their health.
You have seen patients get worse because of the delay.
Absolutely. Absolutely.
Tuesday on 7
I understand it in principle, and we as clinicians understand it in principle. However, when it comes to stepwise therapies, it may benefit the insurance companies, but it's not necessarily going to be the best for the patients in the long run. One example I use is if you had the opportunity to put $10,000 in your bank account right now, and you can gain interest on that, and then you go on maintaining that bank account with that level versus just keeping your bank account where it is and getting the interest on the bank account money that you have now, which would you rather do? So in my role as an orthopedic nurse practitioner specialist in bone health, when we see a patient after a fracture, all the experts that treat patients that are in my patient population, we agree that along with the science that shows that starting a patient on a medicine that rebuilds the bone is very, very critically important at the start, and then putting them on a maintenance. But through primary care, there's really a trend to use some of the older, more stabilized medications that we've had for a long time. If you go to your primary care provider, you should ask about these medications that rebuild the bone. You may experience a conversation that will give you some information, but it might not necessarily take you to where you want to go. So I would just encourage you to look for someone like myself in your area, a fracture liaison specialist, or a specialist who treats patients that are at high risk. If you're not getting the answers that you need, I would tell anyone to do that. And then that way you can take that knowledge back and share that with your primary care provider. But unfortunately, a lot of us in our specialties and in healthcare today, we are bound to certain regulations and protocols that won't allow us to go to the treatments that we feel are best until we try something that may not be superior. And that's concerning to us because we are interested in giving our patients the best of what we have at this point.
So I think what I'm hearing you say is what step therapy is basically trying to treat the condition with the cheapest available drug first and see if that does the trick. But with these specialty medications that actually build bone, they're not necessarily the cheapest out there. So the protocol nowadays with what's proposed by the administration, what's coming down the pike is try the cheap drugs first, those that may slow down bone loss, not necessarily those drugs that we know are proven to actually rebuild the bone. Is that right?
Yes, in essence, yes, that's true. But I think for clarification, I want to make sure to say that any and all of the medications that we currently have available, they're all going to help reduce the risk of a broken bone, okay, and a fracture. And the biggest challenge that someone with low bone mass who is at high risk for breaking a bone, or someone with osteoporosis who clearly is at high risk, they need to be on some type of treatment, okay? So that's what's most important. However, if you take a deeper dive and we look more at the science behind the treatment and why we're doing the treatment, it becomes not so much about putting a patient on a treatment just to reduce their risk of a fracture, but it actually dives more into putting a patient on a treatment that's going to help assure better bone quality as they continue to age. One thing that I want to point out that I really, really would love for someone to take hold of is this, that there are more hospitalizations annually and more hospital dollars spent annually and more patient lives changed annually by osteoporotic fractures than there are breast cancer, stroke, and heart disease.
Wow.
But there has been a significant focus on those disease states, whether it's been policy regulations or lobbying, better lobbying, or more financial support for those disease states, whatever it is. The issue is that we need to join arms, because what we want for our patients that are aging, we want them to age well. We want them to live well. We want them to maintain their quality of life, and most of all, their level of independence. So treatment is significantly important with osteoporosis, but if it's just about fracture risk reduction, any of the medications are going to reduce the risk of a fracture. But the question is can you improve that fracture risk reduction by improving your bone quality first and your bone mass first, and then maintaining from that point? Those are the questions that have to be asked.
Well, what are we looking at when a typical Medicare beneficiary goes to try to seek treatment and they are the best candidate for that person who needs to rebuild bone because they're so fragile? And what are they facing in your experience, have you seen, dealing with these drug companies in the Medicare world so far?
So this could unravel very quickly. So I will tell you real world experience. So I have patients that are engaged, they're ready, they want to start treatment, they're considered high risk, they're considered a perfect candidate for the medications that actually rebuild the bone. We go to initiate it, we have to do a prior authorization, okay? That's kind of a standard thing. It requires extra paperwork, but we have to do a prior authorization. That prior authorization then goes to the insurance company. The insurance company then looks, and what they ask is, they ask certain questions. They ask what the bone density score was. Did the patient have a fracture? Has the patient tried any other medication for their osteoporosis in the past? So we have to jump through those hurdles. One of the biggest hurdles that we found now is that even if we feel very strongly clinically that this patient needs this medication, we will get, Medicare will approve it, but it's at an exorbitant cost for the patient. It will put them in their donut hole much quicker. It puts them in catastrophic coverage much quicker. And if they're already on multiple expensive medications on their drug plan, oftentimes the medication that we would want to put them on for bone rebuilding falls into a fifth tier. They're on fixed incomes, so it's a very big hardship. On my side, clinically, we have to go through an appeals process. There are 5 levels of appeal right now. We'll go through the first level of appeal, it'll get denied. The second level appeal, it'll get denied. I am now dealing in a situation where one of the insurance companies I really feel strongly this patient is unable to take another medication, although they want me to try one, but it won't be safe for her to do so. But I'm trying to get her on this medication, and I'm going to have to do another appeal, and I'm going to have to speak to a judge with the Attorney General's office to appeal this. So, you know, it can be a very costly task, but again, I'm all about patient advocacy, and I feel strong about getting a patient on this treatment, and it's what I feel is best for them, safest for them, based on scientific evidence, then I'm absolutely going to go the extra mile. But I will say it shouldn't be this hard.
Right.
The other challenge that we run into is some of the other medications with where they can actually obtain the medication. It's more costly if they get it in one place versus getting it in another place. So those regulations also become very big roadblocks and barriers to patients that need treatment.
Wow. So that's seems like a big hurdle for just the typical person trying to get this. Are these expensive drugs in relation to the typical drug someone would get for, fighting a bacteria or, just a typical thing? How much difference is there in the drugs that we're talking about that actually build the bone?
Well, the bone building medications are what we call, they're called anabolic agents. And what they do, they're based on hormonal structures in our body or hormonal exposure in our body. And those are more expensive to make. The issue is that we only have 2 of them right now. We have one that's indicated for both males and females, and we have one that's indicated for just females. So the good news is that potentially there will be a generic medication coming out hopefully in the next year or so, which may affect costs.
Wow.
But that is a real big issue. So it's not only an industry issue, but it's also on the payer side of what they're willing to coverage for those medications. The oral medications are cheap. The oral medications, all the medications that we have been out for at least 10 to 20 years now, except for the new one that came out about 15 months ago that rebuilds, that's just indicated in women. So there's been a good history and a very safe history, but it's the manufacturing of these drugs and how I'm ignorant when it comes to how they set the cost, but if they've been made unreachable, what good are they?
Right. Right. So what is the anecdotal evidence as to our likelihood of getting the appeals approved at the end of the day for these folks? Have you seen any consistent history that ultimately they are approved, or ultimately it's a no-go and they have to pay cash out of pocket? What's your experience so far?
Well, initially it was more that we would get the denials and the cost was too much for the patient, so it was going to be too much out of pocket. One thing I will say about the industries, they've stepped up in many ways and come up with, fairly good assistance programs for patients, and also programs that will allow a lower copay card for certain patients, and those kind of things. And particularly talking about Medicare patients, there are some good assistance programs, but the issue is those assistance programs would only qualify if a patient meets certain income levels or expense levels. So a lot of our patients, they make enough money to live on because they were hardworking people, right, and they were smart and saved their retirement, okay, and they did well, so they make too much. But because they're on Medicare and they need this medication, the medication is going to take $1,000 out of their pocket or whatever it may cost depending on their insurance plan. So therefore, they're not likely to choose that medication. So it is a struggle. We work our hardest to appeal as much as we can for patients, and we have a pretty good success rate because, we just keep pounding. That's what we keep doing. We keep pounding for our patients. But there are many times that we have to take a lesser choice clinically to see if a patient if they're going to be able to take it, if they tolerate it, if they're going to be compliant with it. So there's many other factors that we sometimes have to face, and there are patients that we cannot put them on those medications because of the cost.
Now, you've been instrumental in educating other providers from around the country who come and spend time with you to learn how to manage this specific disease area. What would you say is the best rule of thumb for a patient if they're looking for someone with this specialty expertise to know the latest cutting edge treatment for osteoporosis at such an advanced stage? Is there a list or a repository where they can go to and find such a list of experts like this?
So I would like to say yes. I believe that list is somewhat scattered at this point. What I would love to say is that they are welcome to have my contact information and at Wake Forest, and I'm happy to connect them with the National Osteoporosis Foundation, who I work very closely with. I know providers from across the country, depending on what area they may be living in. We are happy to connect them with these fracture liaison providers or other bone health specialists. I think it's important from a patient perspective that you need to know your numbers. You know what's in your bank account. You need to know what's in your bone bank account. So you need to understand what your bone density test is. If you don't, ask your primary care provider to explain it. Be educated. I have a colleague, his name is Dudley Phipps in Iowa, if anyone wants to look him up. He runs a fracture liaison service program in Iowa, and he came up with a statement that I want to give him credit for. And that statement is BEAT, beat osteoporosis, be educated and treated. So thanks to Dudley, he gave me permission to use that. So I want to tell you, be educated, and then talk to your care provider about getting proper treatment. If you don't get the answers that you need, sometimes you have to know a little bit more than we do. I learn from my patients every day. So take that information, go to the National Osteoporosis Foundation website, look up patient information, look at the resources available. We can figure out a way for them to contact me directly if they need to. But we just want to make sure that you have healthy, strong bones as you continue to age, and we want you to be fracture-free. We want you to stand tall for osteoporosis and have a break-free future. That's what we want for you.
That's awesome. As people are looking for this bone density test and they're maybe new to Medicare, what's your experience with the disparity between how women and men are treated?
That is, a wonderful question. So we've had pretty good measures. Now, providers, so patients understand, or your clients understand, we as healthcare providers are held to certain standards, or what we call metrics or protocols or measures of care. And unfortunately, in the disease state of osteoporosis, the measures that are out there right now are not really measures that would matter to you, okay? The measures that are out there are simple measures, things like, did you get a bone density test at 65? Are you taking calcium and vitamin D? Are you exercising? But the measures that matter to you are things like, how do I maintain my level of independence? How do I get my medication covered if I need to? How can I make sure that I'm being followed by an expert who's going to manage this chronic disease? When you have a chronic disease such as high blood pressure or diabetes or heart disease, you are going to be on a medication and you're going to be followed by somebody to manage that. The same thing needs to happen with osteoporosis, because aging is chronic and so is osteoporosis. So as far as the measures for bone density testing, currently the measures are for screening for Medicare patients. A 65-year-old female that's postmenopausal should get a bone density test. There is a screening measure for males at 70. So male 70 can get a bone density test. However, I think that's a little bit late, because men and women start to lose bone at the same rate at 65. If you're diabetic and you're 50 and older, you should get a bone density test, whether you're male or female. If you have COPD or you're on certain medications, medical conditions, prednisone, those kind of things. So you got to start early. The challenge is that we've had fairly good coverage for bone density for women with their insurance for Medicare, but for men, not so much. So we've got to really have a really call to arms, or a call to action, I guess it is, to make sure that we get our measures that match and start getting our male patients tested a lot earlier and get Medicare to cover that.
And what some people like me might wonder is, what is a bone density scan? We always hear about bone marrow transplants and how painful that could be. What's involved in a bone density scan?
Wonderful. So you've seen an exam table in a doctor's office or a provider's office. It looks like an exam table. You lay on the exam table and there's a little arm that looks like this, and it kind of comes across your body. The technician sits right next to you. There's less radiation that comes from a bone density test than from a chest x-ray. So you don't have to worry about any of that. They will scan two sites in your body, usually your low back, which would be your lumbar spine, and usually your left femur area or your left hip. You won't even know what's going on. It takes about 10 minutes. It's painless. Some of you may have had a screening test for your heel. That is not a bone density test, but if you went to one of these things, I believe they do some screening things around the country. I won't name it because I'm not going to advertise it, but the point is that they'll do a heel screen. If they tell you that you have bone loss on your heel screen, you need to get a full bone density. So it's a real basic test, takes about 10 minutes, and it will give you a lot of knowledge for no pain and a little bit of your time.
Awesome. Dr. Ann Lake, thank you so much for spending time with me today.
Thank you so much. And anything I could do in the future, stay strong, everyone.
That's awesome. Thank you.